Hello, good afternoon, everyone. Welcome, everyone, to this second round table of our virtual work on social security and mental health. Today, we're going to discuss about the different models of attentions to mental health. For these, we have three important specialists on the matter: Dr. Anna Heatley, Dr. Shoshana Berenson, and Dr. Anna Perkovich from Argentina, from the Faculty of Psychology from the University in Mexico. And in the case of Anna Heatley, she is a researcher from the Inter-American Conference. To start, today we had a presentation of a book, Melancholy and Depression by Estela Rosellaba, and today we're going to have this second table or session and dynamics in this session. You guys know that have been with us in previous presentations. We're going to have one of the speakers. They'll take like 20 minutes. And then we'll have a second speaker, and then the third one, and then we'll have a Q&A session. Before starting, I want to thank our speakers for being with us today in this international event that we're holding to talk about mental health. As said by our Secretary General during the welcome, it is paramount to think of mental health from a public point of view that would really help people to live in a better way so that they'll be happy and, more importantly, before this pandemic, we're now starting to think after COVID. So, with no longer delays, we're going to start with Dr. Anna Heatley, and we thank our speakers and the people with us during this session. Dr. Anna Heatley is a bachelor in ethnology by the Anthropology School. She's a teacher of psychological anthropology and a teacher at UNAM. She's been a researcher in issues as poverty and loneliness and psychological well-being. Please, Dr. Heatley. Hello, Hugo. Thank you for the introduction. Thanks to Shoshana and Nadia that are sharing here today with me to talk about something that really worries us recently, but also all along my career as a researcher. I've been talking about these all along my research work. And now I'm going to talk about a study that we developed in the Inter-American Conference this year, and that talks about the state of the systems of mental health attention in the Latin Americas. This research work has as a background, and first of all, the debate that has been relevant recently about the way we conceive of well-being. Traditionally, we think of well-being mainly as economical well-being, with some other little points with physical and mental health issues, where we would have a stress in the economic factor. But some advancements and studies have led us to think rather in a conception of well-being which is more integral, and where there are some economic, psychological, and social phases interact to have a well-being state which is more complex, but also adjusts better to the everyday life of people, the way they actually live nowadays. And obviously, the second trend under the context that we studied this, COVID-19, the effects of the pandemic as well as the quarantine that have made evident the importance the environment has and the circumstances we face when we talk about the conditions of mental well-being of the populations. The purpose of this study was to study the state of mental health care, and we try to classify the topic workers and the civil society, because this is more like an everyday debate And maybe it is not that clear and not so deeply discussed as some other topics that have been discussed for so much longer. And also make some general recommendations to enhance the mental health systems from the review we had, so that we have implemented some changes in some countries of the continent. The core ideas I would like to put forward and to give guidance to this study were two. First of all, that mental health is not an individual issue, but it's a social one, despite the fact that obviously the objective must be the well-being of every person, and we normally work with individuals therapeutically and political public policy matters. The focus of every person is actually the product of the interactions of people with the individual characteristics, the environment they live with, their social interactions, among so many others. And the second idea that I believe is pretty important to clarify from the very beginning is that in this research we conceived mental health as more than the presence of or absence of a neurological or mental problem. And this implies that we need a wider focus than the traditional one that has to do with a psychiatric condition. And we have thought of a continuous model that characterizes the absence or presence of diagnosis of problems. So we would then be talking about that all the population would be set in the upper right point of this quadrant, because that would mean that there are no problems or mental issues, and there is a good level of well-being. And one way to understand this concept or this continuous model, we would have to think of a more concrete case. For example, loneliness. We all have left alone. We have had some of these loneliness moments. And loneliness is not a problem by itself that would need to be addressed clinically, but it implies a loss of well-being. That is to say, a person that feels alone considers this as a situation that negatively has an impact on this person. And if this loneliness situation remains in time, even though it's a natural part and common part of an everyday life of every person, it is also true that if it remains in time and we do not solve this in a proper way, it would affect both the psychological life and the physical condition of the people. So loneliness may provoke changes in the social condition. Those that feel chronically alone, they have this adverse surveillance of bad conditions and their behavior, and it has an impact in their physical health, because it's related to less immune response or worse immune response. And the absence of problems does not imply an optimal well-being situation, which is, even though not considered as an illness or mental issue, it does need the conditions for people to solve those states of with the resources as information, administrative strategies that would allow them to address these situations, and maybe the support of professionals that are experts in these topics. The study by itself has three steps or three phases. The first one would be a conceptual analysis that would give birth to the quantitative analysis. due to previous studies, and finally in comparative analysis of three countries in the region that would allow us to finally have a series of recommendations that would allow us to enhance or give more elements to the revision of the systems in different countries in the continent. Given the fact that we have two experts in the Mexican system and the Argentinian system, I would not take too long in the part of the review of the procedures and the infrastructure of the services, etc. But I'm going to focus on the first part that deals with the reflection on the difficulties that the mental health attention faces, and that allow us to understand why it is so complex to solve. It is not for free that no country in the world has implemented and working a system which is efficient for the mental health attention. Mainly, if we think of community, let's say, approach. And this is because we are facing a very complex problem that we're still finding answers for. We are nurturing from the advancements that we are having thanks to research, and that implies that there are no simple answers. For physical health, we do not have simple answers. So it is more obvious for mental health issues. And I would like to reflect a little bit on how mental well-being involves a great amount of factors. On one hand, we have emotions, perceptions, conditions, and behavior. Each and every one of these factors influences the rest, and they give feedback to each other, and in a mental state implies all these dimensions. Mental health also involves different factors such as the functioning of the brain, maybe dementia or Alzheimer. It implies chemical or electrical balances such as epilepsy or depression, and involves also the interaction between the brain, the mind, and the body, as it can be illustrated by the Tourette syndrome. And finally, the interaction between the mind and the surroundings, that is to say, autism or things like that. And given this vision, we have to add also some factors that may trigger this kind of illnesses that may be the predisposition, genetic predisposition, such as schizophrenia. Is important because it interacts with factors of the surroundings or the development process in the childhood, which are associated to the development of in childhood. And we also have the influence of the experiences along life. And maybe we would think of social anxiety problems. So giving attention to mental health, specifically when we have a wider scope rather than the diagnosticable problems, implies all these phases that are giving feedback among them in an everyday life of people. So the complexity of this phenomena, which indeed is a continuous process, and it implies a very delicate balance of many factors, along with the advancements and discoveries maybe which have transformed the attention, are very recent, such as psychotherapy, maybe has 100 years of existence. Medicine such that have been around for 50 years or so, added to the fact of the causes of problems may be internal, but also have a social factor which is important, and some cultural manifestations, and to the stigma that we have about the people that have something that may halt the search of attention, or that make them neglect the need of attention. So this makes this pretty complex. Current systems are not ready to face these challenges, and it gives us hints about why we're only finding ways to face this complex problem in a better way. I would love to think about some of the discussions we have proposed in the study that we'll find the CISA webpage, and that has to do with the features of mental health attention that are very important challenges to be solved in the implementation of an efficient system. The problem here is that there are some mental health illnesses that are clearly linked to factors that may be corrected or solved in a certain way, but in the most frequent problems that we see in population do not fit that category where we have a very clearly identified pathogen, like it would be a bacteria or virus in the case of physical health, but it's the interaction of different factors that are constantly changing, and they are very complex and involve other people, not only the person that is suffering from this illness. So it's not clear where there is a pathogen where we would be able to eliminate if we think of anxiety or depression or the use of substances that cannot be excluded. So there is no pathogen that we may take away for the person to get well, because he cannot be subtracted from their social life or context so easily. And as it happens with the post-traumatic stress problem, there is no problem with this person, but there was a problem in their environment, and she was exposed to trauma or risk or threat important situations, and those trigger in the person a series of problems that were not originated in him, but the problem was the environment, and those are the things that we have to prevent or correct so that people will not be exposed to this kind of contexts if we want to prevent a problem like the syndrome of post-traumatic syndrome. Stress. And then, secondly, we have universal illnesses or cultural issues. Literature has talked about some mental illnesses that are present in certain cultures and in some others no, or the symptoms vary from culture to culture, and this makes us think of the importance of adjusting diagnoses and treatments, as well as the way we face this kind of problems, given the context we are in. The answer is not in the diagnosis and the symptoms of the person, but in the symptoms of the environment. That is to say, having a treatment or a system of community services would have this logics where we see beyond the person and we worry about understanding what is happening in their social context. I will give further information about this in a little while. And while this I would like to talk about the third point and reflect a little bit, is if we're searching to rehabilitate or control a certain behavior. Identifying a mental health problem is related historically to the problems of behavior, and the notion of madness is related to those behaviors that are apart from the social expectations. And this feature has two characteristics that are important. One is the productivity and efficiency in standardized surroundings, which is the working environment or educational environment. So if we're expecting a productivity level which is efficient of certain behavior under certain standards, then people may face the identification of their environment as problematic agents. So if we think of the hyperactivity and attention deficit syndrome in children that are within standardized educational systems, where they expect from the kid a specific behavior, and maybe the kids have not developed for that kind of behavior, maybe these kids may be diagnosed with this kind of problem. Whereas we can see that this standardized environment is causing or is not being, let's say, appropriate for that kid in particular. And the second point is the moral or the correct thing to do in a specific cultural environment. That is to say, we think of those times where homosexuality was considered as a mental disorder. This diagnosis has to do with a moral idea of what is correct socially rather than the well-being of an individual. That is to say, homosexuality becomes a problem when the society considers that behavior as something which is not desirable or something which is not correct, and not when the person is suffering of any kind. So these kind of reflections are important when we think of implementing a system, a state system that would help the conditions of a people in homogeneous ways, or that imply a certain standardization. And another point that I think it is important is the way to, feeling well or bad. What is the reason why we feel well or bad? Many problems are associated or determined by the social circumstances or cultural circumstances. And in those cases, if people in their interaction with that environment may suffer from consequences due to the social organization where they participate. And so that makes us think that whether it's desirable to keep a social structure that nourishes from the psychoaffective well-being and many of their members, and if it is desirable to feel well and to be socially functional through pharmacological treatments to give a social structure that makes us feel bad. For example, in the conditions of the work market, we have many jobs that are characterized for being activities that are not very satisfying and not so productive, but that they receive a better payment compared to other activities that are more useful for the society, such as doctors, nurses, or teachers, whose payment is not the same and their work conditions are not as good as those of certain other professions. So the reflection here should be, we have a job where document processing would be better paid than taking care or feeding or caring for other people. And what are the effects in the psychological well-being of a person that has a job where she feels, let's say, complete, personally speaking, but that they have to give up because the money is not enough for them to live in a proper way?
So, all these factors we need to reflect upon when talking about the implementation of a mental health state system. And again, all these thoughts, which are not new, by the way, they've been around for long in the making. in different sectors and throughout many disciplines. But well, they complemented the traditional model of mental health. So maybe after 2001, where the WHO had the year of World Health, and after different reform processes to these models of mental health, just to make changes in these traditional models, something that will bring us closer to what we now know as a communitary model. So these criticisms to the traditional model had to do in the way the attention to mental health was carried out in public or even private systems, where there were involuntary confinement. People ended up being confined in psychiatric hospitals, not necessarily under proper control or willingly. And where there were a lot of conditions for abuses or violation to human rights, and where the possibilities of rehabilitation were a little bit opaque by just keeping the people under custody, under guard. And that there were no efforts to bring back these people and reinsert them into their local contexts or communities. So after all these criticisms, we started working on the communitarian model, and I would like to emphasize this is not exclusive to providing attention at primary care centers, but this attention within and for the community, something that responds to needs of the community, something that make people participants of all the different stages of the treatment or reinsertion. For that matter, it is characterized for having multidisciplinary teams with transdisciplinary focus to provide more complex treatment, which are necessary, by the way. Where there are very important emphasis is placed in reinserting people into their communities. So based on this, we revised 3 implementations of the communitary model in Latin America in 3 countries with different systems focused on different levels of advancement in terms of the way they tend to mental health. And these countries are Argentina, Chile, and Mexico. So I won't take any more of your time or Nadia's and Shoshana's time. We'll talk in depth about this. I would just like to mention a couple of points worth highlighting. In Argentina, for instance, legal administrative mechanisms that they have implemented to warranty the protection of people involved with attention to mental health care, the varied development of human resources that they have in the country, and the implementation of regional communitary model, particularly in the province of Rio Negro, which has become a byword to attention to mental health in the region. Second, Chile, that we highlight because of a very ambitious conceptual and institutional design that has bet on the development of human resources, especially recently, and with very diverse services, with rural scope, something that's not easily seen in the region, at least. And finally, the case of Mexico, where we've developed units of medical specialties, like these devices of ambulatory community services. That's working through 2 independent systems. I wouldn't say parallel, one dependent upon the Ministry of Health and another dependent on the institutions of social security, where there's been real advances in the implementation of communitary model. Thus, those devices depending on the Ministry of Health and services. It really depends on social security. So those are completely traditional in the psychiatric model At least it had predominated until recently. But well, there's a lot of information and investigation in the subject, especially because of two national surveys on mental health. I will not stop to read these. These are hard facts. We would probably go over them in the Q&A, and I would like to close my participation with some general recommendations derived from all this analysis, and that put a cap on the study that we're about to publish. So seven points. Number one, we need to have quality attention with good bedside manners, and it's crucial for attention and treatment not to increase suffering of people reaching out to the services. So the first responsibility of the personal and the whole system in contact with users should be preserving well-being conditions, the largest degree possible. So that should be prioritary. Point number two, adopting the two continuous model, that is to say, distinguishing between a disease or a mental problem. Number three, the development of transdisciplinary teams. They should be more complex in the way they work, they treat people, and well, that they cover both items physically and economically for a large amount of population. And number four, there should be some sort of tagged budget for this because the budget devoted to mental health is still very low, give or take 2%. 2% of resources for health go to mental health. So health, in broad terms, physical health receives 98% of attention, while mental health only receives 2%. So that needs to be urgently modified. Also, we need an updated standardization with mechanisms of follow-up, surveillance, and sanctions, something according to international standards with respect for human rights, and something that's geared towards the attention that we should provide through institutionalized services, whether public or private. It's also important to generate information on mental health, something that really allows us to assess advances, but also to design better strategies based on the knowledge of the needs that we have in different contexts we're talking about in each country. Of course, there will be local characteristics, and that's important to take into consideration, and that's only possible when we have information, updated information, that is, and when we sensitize people through information generation that this subject should be dealt with. And finally, but not less important, I think it's vital to destigmatize mental health issues for the people with the mental issues and their families, and to foster self-care and the assessment of mental well-being. Because there are a lot of social dynamics on the day-to-day basis that have not really been studied in full. And in closing, I have this thought I would like to share with you. It talks about the importance of considering this as a complex social problem, because mental well-being is a task for everybody. I mean, not that everybody should look for their own mental well-being, but rather we should all contribute for everybody to be able to maintain and preserve sanity, peace of mind, health, and well-being. Because ultimately, it's beneficial for us being in an environment where people are feeling okay. And that's also an advantage in terms of in other facets of social life and responsibilities of the state. So with this study, we're calling upon people to place emphasis in priorities of public policies and in the reflection on of the orientation toward this subject in different countries of the region. So with that, I would close my presentation. Thank you. Thank you very much, Anna, for your presentation and all the effort and dedication that went into the work. For those asking in chat in the coming few days, it will be readily available in our webpage. So we're just waiting on finishing the editing process, and you'll be able to download it from our webpage. Now I'll pass the floor to Dr. Shoshana Bernstein-Groen. She has PhD in social psychology from UNAM. She's level 2 researcher in national system of researchers. She's head researcher in National Hospital for Psychiatry. She's also a faculty member in the Escuela Psicología de México, and she does a lot of research on addiction. And she has over 65 papers published, nationally, internationally. And again, Doctor, thank you very much for your participation in this event. And without further ado, I will pass the floor to you. Perfect. So thank you very much for having me. So I will show some information about the diagnosis of the health system in Mexico. Tell me if you can see my screen correctly. Yes, doctor, perfect. Awesome. So again, the idea behind this presentation is to complement what Anna already mentioned about all the needs and what is it that we need to understand to improve the attention to mental health. I think that the data I'll present reflect with information and hard facts this condition Anna referred to during her talk. So again, the idea is to show you the information that we have from the piece of research that we've conducted on the status of the health system in our country. And some comments like Hugo said early on that we need to reflect upon after undergoing a pandemic. So this piece of work is divided into 3 major items that I'll touch upon very generally. So on the one hand, we will see the characteristics of the gaps in attention to mental health, the status of mental health system in Mexico, and things that have changed after the pandemic. So you've probably seen these figures already. But like Anna mentioned, after 2000, 2001, there was a very important change in paradigm in the way we understand mental disorders, where we start seeing all these numbers that demonstrate how mental disorders have a very specific and important weight before handicap. They're probably they don't weight so much in mortality, but people with this type of problems do have severe handicap problems and also problems regarding their well-being in the daily life. So in this slide is clear to see which are the main disorders related to these handicaps. And here in the red, you have mental disorders. And they take in 8th place, substance use, 16th place, violence, and self-harm. Because we know that violence and self-harm are risk factors for mental disorders. This slide talks about the burden of mental disorders. And well, we see that years of age based on being handicapped. Well, this analysis really analyzes the burden of a handicap in mental illness, and we can see how percentages increase. Here we can see that 16% of this burden of life based on being handicapped in our country are due to mental disorders. And we see different results in different countries, a little bit higher in South America and where we're at in Mexico. And we also know that one of the most handicapping diseases are mental disorders. And, well, a budget allocated to mental health in our country, in the region with exceptions like Argentina and Chile, like Anna mentioned, is a very low budget, and the burden of disease is 8 times higher than the budget that we have to tend to these disorders. Something else that we need to take in consideration is that mental disorders happen throughout the whole life cycle. So it is important to give attention to them early on. Prevention and then attention. People thought that children didn't undergo the disorders like stress. But studies mention that they do, and that the onset is really early on in their life. Something else that we should analyze, because health service and well, the policy that we have currently is geared towards how to improve attention to decrease these gaps in treatment. And gaps in treatment have to do with the percentage of people that need treatment at one point or another and are not getting it. And in this slide, you can see how developed countries show very important gaps in treatment. In these countries, gaps are between 35 and 50% now in developing countries. This go from 76 to 85%. And in our country, well, this go between 67 and 79%. So what we're seeing here is that in a developed country, only half the people who need it are getting treatment, and in our countries, only 2 people out of every 10 need treatment. So it is plain to see that this gap in terms of treatment is very big. So what are the causes of these gaps in treatment? So there's a lot of causes and different barriers. But amongst the main that we've seen is that there's some sort of delay in looking for medical attention. So researchers done by the National Institute of Psychiatry, this piece of research tells us that someone with a mental disorder can take up to 13 years before looking for professional help. And for the case of anxiety disorders, 3 years may elapse. And this might have to do with what Anna mentioned a while ago, which was how we conceptualize the disorder and what type of service we render. And this makes that many times there's not a communication. So there's no communication between people looking for treatment and people giving the treatment. Now, historically, on the other hand, mental health has been really separated from health in general. And that has brought about a lot of stigma, a lot of discrimination, and for people not to understand this as a disease, but rather a problem of not having enough will, being lazy, but not as a disorder or disease. And like Anna mentioned, this has to do, a lot on the one hand, there not being a space, a part in the body where we can feel it, that there's no laboratory studies that can tell us, oh yes, you have cholesterol, high cholesterol levels, or there's not an element for us to be able to measure our anxiety or depression. Of course, there have been important advances in all MRI studies allow to see certain changes in the brain. But these are really complex studies. It's not like I mean I just draw blood and I know how I am. So this has made the gaps increase, gaps in treatment. But there are also a series of institutional barriers that don't allow people to get treatment. Not the characteristics of the services, the fact that for a long time these were separated from other services. So going to a psychiatric hospital was very stigmatizing, and it's still the case. And we also have a very serious problem in terms of availability and access to services. That is, say, where the services are at and what people have access to them. And well, this perception that treatment is not effective. Now, in this envision of what happens in mental health and the complexity of the service, and many times with people we've interviewed about what their perception is regarding the efficacy of treatments, they tell us that, well, it's not like me having the flu. They will give me an antibiotic, and the third day I'll feel way better. Here, maybe 20 days can lapse, and well, there won't be any signs of improvement. And it's hard to understand sometimes, and is perceived as the treatment not being effective. And again, like I mentioned, stigma and discrimination. And here it's important to mention the stigma is not only to the outside of the health system, but to the inside of the health system. For instance, general hospitals don't have that many mental health services because there's huge lack of knowledge and stigma. It's like, how are we treating this patient? What are we going to do with them? What happen if they're like really ill? So they rather not render these services, and that provides for a lack of connection between mental health and the health system. Now, what were we doing prior to the pandemic? An important item that we need to analyze when assessing a health system is how are we doing in policies, laws, and plans, because if we don't have these elements, these relation elements, well, putting them to practice will be way more complex. In this sense, in the last piece of research, the WHO really worked to improve this option. We can see that in these countries, in different regions of these countries, and in Mexico, where we do have policies, programs, and laws will go according to different human rights organizations, which are revised kind of periodically. But the large problem is that even if we're doing good in policies, laws, and plans, they're not always put into practice. What other conditions we find here? Well, that the budget that we have to take care of mental health problems is usually limited. But aside from being limited, its distribution, its widespread, is not as it should be. Like I also mentioned, that there's a lack of balance between the percentage of this total burden of the disease brought about by mental diseases and the percentage that's allocated. In Mexico, give or take 2% full expenditure in health goes to mental health. Nevertheless, most of these resources are used in psychiatric hospitals, third-level hospitals, and there's very few budget left for communitary attention, what Anna was talking to us about. More attention towards promotion and outreach mental health. And that has to do with this historic backlog I was talking about, because the attention is there. If we were like very radical tomorrow and we shut down all psychiatric hospital in Mexico, there would be no attention to mental health. So that's our reality. If it doesn't happen there will be no attention to mental health. So the bet under this new administration is kind of shading or start changing little by little the services in such a way that we can strengthen these numbers. Like I mentioned a while ago, this is the attention axle, attention mental mental health in our country. And this piece of research that we did on mental health services in Mexico, this was done a couple of years ago, but we haven't had the budget to update it. However, I don't think that this has changed very dramatically, but it is plain to see here that what we would hope that specialization would be carried out in the specialized hospitals, third level, known as psychiatric hospitals. However, I think that these hospitals also offer, they offer ambulatory services. Now, what about the availability of mental health services in Mexico? It is plain to see in this chart where we're contrasting the states of the psychiatric hospital services in primary attention, first level services, and services in general hospitals. Yes, there's been an important advance in first level attention centers or primary attention, which is the same thing. But that's topic for another discussion. We see that there's been an important increase. However, we cannot say that this has changed or the attention this level has changed. There's been more people hired working at this level. However, people usually go third level because that's where they really think they can find a solution to their problems. Plus, the services at first level of attention are not really homogenized. You cannot find them at every level. There's not always psychiatrists available. Medication's hard to come by. That's why we see the discrepancies. And again, here we can see how is it that mental health services in general hospitals are have not been used throughout the years. Now, another important element that we need to analyze, geographic barriers related to this services. So it might be true that we don't have enough services. It's also true that the large majority of these services are located in large urban areas. Most psychiatrists working in Mexico can be found in 3 large cities or urban areas, which are Mexico, Guadalajara, and Monterrey. And that there are several states in Mexico that might have 1 or 2 psychiatrists. Some don't have psychiatrists, for instance, and that makes for a clear inequality in the rendering of the services. But let's not only think at the state level or the city level where we can find them, but populations themselves, depending on where they're located, can have less access to the services. Let's say I live in the Sierra region of Puebla, supposed to living in the city of Puebla, so that makes for an even greater inequality in terms of the rendering of these services. Like I mentioned earlier, also human resources are insufficient. You know that Mexico has been cataloged as a country of medium-high income. I'm not sure that's still the case, but you know that the World Bank and all these large financial institutions making this analysis think so. So they place Mexico as a country of medium-high income. And we can see in this chart that even when talking about human resources, well, they're below what some low and medium countries in the same region report. Another important problem I already mentioned is that mental health in the first level of attention is not really consolidated. And the program, this government, I hope they can pull it off. Well, most of mental disorders should be treated there, and all the work of attention should be through community outreach. The bet should be on how are we going to maintain mental health, as opposed to how can we be cured of a mental disorder. That should be the bet. And what I want to convey through this slide is that when asking throughout the first level of attention, what we know as health centers, how many of these do actually have assessment and attention protocols for mental health problems? We are going to one psychologist, psychiatrist, at least once a month. Only 30% of centers in the country reported doing that, and less than 15% had received some sort of update in the subject matters, whether physicians, nurses, social workers, or even psychologists present in the centers, none of them have received any type of training in these issues. And another important element I already mentioned is how many of them had availability of at least one psychotropic medication for each of the most common psychiatric disorders.
And this is observed between the 21 and 50% of the first level centers in our country. One more important factor that has been around for many years internationally and the great worldwide organizations is the link with the social civil society. And for many years we've said that the users of services and their family members and the general population has to be linked not only on the way the attention is given, but by building public policies and regulations. And in our country, we have very little information on how this link is given with the few organizations that we were able to contact. They told us that less than 20% of them would interact regularly with some kind of mental health service, regardless the level, and 20% of them participated in a parliament or a discussion for the formalization and implementation of public policies around the mental health. And they were also telling us that there was a little link between the organizations and social institutions and health institutions, because we know that mental health is related to a series of conditions and a series of social factors that, if not worked together, it is pretty hard to enhance the attention of mental health. And there were very little programs where this would be mentioned, such as the way for people with mental disorders to work, or maybe some benefits such as houses for this kind of a population. So what was the situation before the pandemic? We have segmented the health system, and there was no authority that would gather all the attention of mental health in our country. It was pretty segmented and with a lack of governance. Social security based on employment, and these would make people with no job or without any security or insurance. Then we created the popular insurance that, at least in the mental health attention, was non-existent. One important element is that mental disorders have not ever been as a priority, and since it's not being as a priority, we have not budgeted, and attention at different levels is not demanded. So this obviously has an impact on the gap. And the money allocated for mental health has not been well balanced if compared to other diseases. So people would say, whom should I give money to? For those that are killing, those illnesses that are killing people, or those that do not allow them to work? So we perceive there is an increase in doctors and psychologists in services of first level, but it's not reflected in the kind of attention granted in these places. And we see an increase in the number of psychiatrists, but these are located in 3 big cities. And this is only an example for you to see that in Mexico City we have 20.7 psychiatrists per 100,000 inhabitants, while in Chiapas we do not have not even one psychiatrist per 100,000 inhabitants. So what has changed with the pandemic? What have we seen? Well, we've conducted several research and we've seen with a lot of information that mental disorders were increasing before the pandemic. But from the pandemic on, there was a great increase, an important increase. And we believe that it is going to be increasing. And we do not have you know, many people say that mental health is going to be the second great pandemic. And the truth of the matter is that we were not ready for this. What has happened? From what we already had, we have added some conditions that increase the probability to have mental disorders, such as the people that have lived with the virus warning that has not been solved, distribution of responsibilities and overload of work. It is important that the conditions that we have been coping with from the COVID-19 presence have made evident the way people are overloading with work and greater responsibilities than men. And in research that I was invited to participate, we studied mothers that are doctors and that have little children. And there it was clear this function. And we've seen clear increasing in domestic violence, in child and adolescent abuse, a greater consumption of substances, problems to comply with the social distancing, and that produces problems among populations and locking down and a lack of trust and doubt about on what is going to happen, poverty and lack of employment, and the economical conditions associated with the COVID-19. A lot of fear, anger, preoccupation, and sensations that clearly we do not know what they are, but that they make us feel bad, such as these emotional disorders. So before this view, we have thought on how to rebuild the services, and the way we have to think together with what we already have as a pending issue in the attention of mental health, the way we have to think of intervening in order to give answers to these situations we're living with. And here we have like a little ladder, and the way we could actually think of the interventions according to the seriousness and the sensations that we have. Because it is true, not all of us have the same conditions with this COVID-19 condition, and neither all of us need the same treatment. There might be people that may suffer from stress or when we leave situations like the way we are going through, but a certain empathic situation may give an improvement in this. While there might be some background conditions that may be worst with our current situation, and they would need a very much more specialized treatment. So what I want to show here is that what we've already said about an attention that would mean giving everyone what they need, then we will have to think of it more carefully before the presence of COVID-19. And we also have to think of what may happen in the long run, such as the post-traumatic stress for the people that had to be intubated or those that have passed away. People that have not even had the chance to have, some mourning or maybe go to a grave. So this model would have to be thought, given these problems that we are facing now. So what is the suggestion that for a long time has been there that I was talking to you? It's this pyramid that the WHO has been talking about, where the greater attention should be in the community actually to think this emotional well-being and avoid these mental illnesses and all the work at the first level of attention and all the primary prevention work may be done at a community level. And indeed, the psychiatric hospitals should also have only crisis and serious disorders. The truth of the matter is that in Mexico we have an inverted pyramid, and most of the attention is given in these specialized places. I'm pretty glad, and I hope that with this new articulation that we're having, and with the services of psychiatric attention and CONADIC, we will be able to boost this model, which is the one that would allow us to really enhance attention and the well-being of the population. So what would COVID has allowed us? Good and bad things, but it has made evident the deep inequities in attention. They were evident before the sanitary emergency, but it has also confirmed very clearly what we've been doing for a long time, which is the relationship between the mental and physical and social determinators. It has made evident once again the most vulnerable groups have less options for attention, and we then have this inequity as well as the lack of research in the services of health, which is having an effect nowadays on the way people are being assisted before the pandemic. Many of the services have been interrupted, and this we do not know what the impact is going to be. For example, the people that were under treatment that had to close due to the pandemic, and what happened before this loss. And also, but also the most important is that I believe that all these things that we've been going through is that we have had a lot of work to show the importance of the attention of mental health. And I believe this can be a great chance for all of us to prioritize this attention and to give all the impulse it needs. And I have this little phrase here that made by the OMS director, where I have this little quote where he says clearly that we're already living the consequences of the pandemic. And if we do not take action now, which is now the beginning, and if we do not seriously think of having a great investment in mental health, then the sanitary consequences, social and economics consequences of mental health, besides COVID, will have a great consequence. So this would be it. Thank you very much. Thank you very much, Doctor, for all the comments you've made on the information about the mental health system in Mexico. We have several reflections and we have several questions now in the chat box. But once we finish with the presentations, then I'll let you know. Then now we'll have the participation of Nadia Perkovich. She's a psychologist and has a master's degree in mental health, public health, and she works in the National University Arturo Jauretsch. She's a member of the Association of Mental Health Rights, and she is a technical assistant of the Hospital Esteves in Buenos Aires, which is a neuropsychiatrist in modification of institutions. So, dear Nadia, the floor is yours in order to listen to you. Thank you very much. May you please turn your mic on? Oh, sorry. Hello, good afternoon, everyone. I'm not going to use a PowerPoint slideshow because we have some technical issues with connectivity. Now, what I'm going to talk about is mental health with a right approach. And I'm going to talk about how this works in Argentina. And the very first thing that I have to think of, what implies and why do we talk about mental health without an approach on rights? And why do rights are going to be the center, are going to be in the center of the practice? and it has to do with the historic history that had to do with excluding people from the everyday life. So being able to think of mental health from the point of view of rights would imply not only having a regulatory framework where in Argentina we have a law with mental health, but there are also some international agreements that my colleagues mentioned. But it is also to think of the person that is suffering with mental disorders as somebody that has a right to be a citizen. So when we talk about mental health focused on rights, we have to think first not only in the mental disorder, but in the concept of the psychic suffering, an idea, not an idea of a state, but of process where everyone in a given circumstance. Recently, you were talking about the consequences of suffering from COVID, and related to this, what is happening. So that person may suffer a moment of subjective disorder. That does not mean that it's a mental disorder like the stigmatizing diagnosis that would always happen, and that would lead that person to be confined or locked down. So this has to do with our. We have to break with the idea of the danger associated to this disorder and reclusion. The only way, or as the only way to cure this problem. So, if I get sick in the community, I cannot be well apart from the community. It is pretty important that the attention would be within the community. This is why we have to work on the social production, you know, and in the social life in the community, or the community social life. So we have to remember that in Argentina we have a national law of mental health that it was passed in 2010, and it was ruled in 2013. So that very first sanction was without obstacles in both chambers of legislators, but regulation took a little time to come, and the implementation we still do not know. We're under the process of implementation. On the reclaimatory decree that I was talking about, the way we have to implement this law would mark 2020 as the end of mental care places. This was not able because we have a neoliberal government that halted these actions. But even before, we saw a lot of reluctances because this great hospital for mental disorders, it was like a refugee, not only for people that suffered from a subjective disorder and that were think of our reinsertion in the society, but it's also a place where we deposit all the diverse and everything that does not fit within the the health system. So we have this stigma that was mentioned by my colleagues, and always there is a third level hospital such as an alternative. Then we use it and we avoid some other modes, let's say. Before talking about the mental health national law, I'm going to talk about the background. We have the Caracas Declaration that will turn 30 years. That was the declaration that I was to say that mental health homes, retirement homes, were not a place to be cured, and they should not exist anymore. And Convention of the Rights with People of Disabilities in 2008, that would also mean something pretty important. That was took by the legal system in Argentina, and then the last amendment of the civil code that I will give further information about that later. But in 2015, the civil code was amended, and we have some points that figure in this convention, such as the juridical law capacity that the person has, and instead of inhabilitating them for lifetime, or somebody that would make a decision on their behalf, so that according to the need they would need somebody to accompany them along the system. So I named this background because it might be that there might be countries or regions without loss of mental health. But this background is useful for everyone, and it would be useful as a low basis for certain actions. I work in externation a program of a psychiatric hospital that has been there for 21 years, which is about mingling houses, places where women mingle that have suffered, from reclusion in mental health hospitals. So they have, like cut any kind of communication with their family members. So these women that are together and are followed out by a team, and they're given a home due to the program was designed from the Caracas Declaration. So the program where I work comes from 1999. 11 years later, we have the National Mental Health Law that ratifies all those actions that were being around. And I also mentioned Rio Negro. We didn't have this. There was this process, such the institutionalization of psychiatric, the institutionalization, and they were substituted by community centers, and it was possible to do this work. Now I'm going to focus a little bit on the law that was set as a little summary of what I mentioned before, but it's too much. But I want to mention about the definition of mental health, which is a determined process by a socio-economical and cultural and biological, psychological process, whose representation implies social constructions linked to the human rights of the person. So it is important. We have this idea of the mental disorder to think of this problem as a process. And there's another article, which is Article 4, that includes addictions within the mental health disorders, something that may be obvious for those that work with mental health. But because we also see many people with pathologies that indeed their mental health is like residual part of health. So the people with a problematic consumption would be a more marginal sector in the field of mental health. So by including these affections within mental health was an important step. Now, we talked about the presumption of capability of all the people. That's pretty important. The national law also would talk about the participation of users of social network users. And we were talking about civil society organizations. Having the voice of the users within these systems is pretty important. And it's something that we're working with all the time. We talk about the deinstitutionalization and interdisciplinary and intersectorial matter. What does this deinstitutionalization imply? The prohibition of creating new mental health hospitals after mental health attention regarding the internation should be done in general hospitals, and it'll also talk about a reinstruction of budgetary resources towards the community attention. The law of mental health establishes that the 10% of the money for health should be for mental health. That's far from being true, but that's a very interesting point. And relating work, general hospitals, and talking about the law, we have to work a lot about the stigma that we have between colleagues related to these serious mental disorders. And then this law has a very important part dedicated to internation or hospitalization, which is the most important part. And it's going to say that it's a therapeutical character of limited use, restrictive, and it has to be as brief as possible, and like 30 days maximum. And then we have to have review mechanisms and that hospitalizations in order to solve household or social problematics cannot be used. So we have people that have been hospitalized for 10, 15, or 20 years because they have no place to live in. And this crisis, repeated these pathologies, even associated to these mental care hospitals. But this was not modified. Then I believe this is basic related to the mental health national law. I was telling you about a brief comment, but I would go deeper in relation to what was the amendment of the Civil Code. Before this amendment, we were saying that in 2015, they would say that people with mental disorders were declared as unable or incapable, and they had like a public carer or somebody from their family to make decisions on their behalf. And this sentence on this judicialization of mental health did not include the perspective of the user, but it did not include the perspective of the health team. Now we have the perspective of the health team, and the hospitalization should be reviewed for every 3 years. So the legal capability of these people is reviewed every 3 years and is reviewed by an interdisciplinary team. This is fundamental. I see that you had a comment related to this publication, which is called Mental Health, Human Rights in Human Mental Health and the Implementation of the National Law of Mental Health. It is digital, and it gives you further information about this law. But what's the law, and how do we make this law to be not effective? And I think it is a little bit of like the danger, and I'm saying that this law has 10 years and it's far from being implemented. So it is important to be able to think on how we can do and how we can work in order to implement the law. The very first thing that we have is that if you talk to people and mental health workers, the lack of intermediate appliances. That is to say that Susana was presenting this pyramid where the greater amount of services should be in the community, and indeed we are in a hospital-centered model where this gap of treatment that we were talking about has to do with the fact that what we get, from the serious case goes to the psychiatric hospital, but we do not have an early attention program in the communities, and many times due to the kind of the way we deal with this, there are homicides, and there are municipalities where we have these sanitary facilities for mental health, but their demand is greater than what they can actually deal with. So they think individually, they do not think in the community attention or communitary attention. And I want to call your attention to this because when we talk about community attention, generally we associate this, the community matters is everything that happens outside a hospital. But indeed, let's say you can have the mental hospital in your head and work somewhere giving attention of this kind, hospital centered, without considering the other set of rights. So the idea of thinking positively based on the community has to do with not only going out of a hospital, but also thinking of that community that I'm going to work with has resources of their own, and those resources have to be in place in order to work with the complexity of the situation and what happens.
And putting together networks with the people from civil society, clubs, and so on. So that's what I understand by community. And that's what's far more disarticulate to me. So I think that's a major problem in Argentina, the lack of hospitals programs like the one I told you about, the one I'm working in, that accompany women who have been committed into psychiatric hospitals, or even providing them with a community center with activities, some more activities in work inclusion. So those are the type of activities that we're missing, even outside clinics with modalities that can reach more population. And another large problem, which I think might be the reason why this Mental Health Act has not been implemented, is the poor communication between the sectors. Because we cannot think that mental health problems, with their huge complexity, are only mental health problems or pertaining to the health sector. Because someone who has been committed a bunch of years in a psychiatric hospital, logically that person doesn't have the possibility of being reinserted into society. That person will have a lot of problems in getting a job, in having a dignified income, being able to maintain a household. So housing problems undergone by a person who has mental health issues should not be covered by the Ministry of Health, but rather the Ministry of Housing. So in Argentina, this decree by the Act Mental Health, well, the National Act of Addiction should participate in this, especially now with the pandemic that makes all the budget and all priority health issues has more to do with the emergency as it relates to the pandemic. But we're starting to work with CONISMA in some provinces. So at least us, as a federal country, even if the law is natural, that doesn't guarantee coverage in 100% in all other jurisdictions. Because a jurisdiction might conceive the law differently with different implementations, health something provincial. It depends on the provinces, not national state. So that there aren't many health sectors national level. And another problem, aside the different jurisdictions, the differences between the sectors. We have public hospitals, private hospitals, and social security hospitals. So maybe in the public system you can have more control, but this is a bit more complex in the private system, trying to implement this type of radical reforms, like the total institutionalization in the private sector. So these are the main difficulties. I guess, but it's not all bad news. I would like to tell you what's going on in the province of Buenos Aires. So I work as a consultant to a women's psychiatric hospital in Buenos Aires, with 540 women patients. It's a beautiful hospital with the pavilions, sections for chronics. We have women who've been there for a long time. But I mean, one of the big problems that we have, chronic patients, another big problem is that people's, especially with dual pathologies, are more impulsive and they keep coming back. So people go to the hospital, they get a response, they get stabilized after being there for a while, and when they go back to the community, they cannot really fit into the community, so they go back to the psychiatric hospital, and little time after that, actually, 60% of commitments that we had in past year are second timers, and almost half of them went back before 6 months after being committed. So because of these problems in the province of Buenos Aires, with the change in administration last year, we have a mental health board that's really committed to the Mental Health Act, wanting to push forward the reform. As a matter of fact, past October 10th, the Day of Mental Health, they presented the adequation plans for the monovalent hospitals. So in that hospital with these problems, we're thinking about community work modalities, understanding health as something broader than the specific pharmacological treatment or psychotherapeutical, but thinking as something more integrating. We will still work, obviously, in emergencies. We will work a lot with the chronic sector to be able to warranty the continuity of care once they go out of the hospital. Because people are afraid of that. I mean, what happens with workers once we're done with psychiatric hospitals? That people will be destined to accompany and to give follow-up to care in the community of people who go outside, who leave the hospital. So we'll see what we need to rehabilitate. Maybe because of age, that person cannot be rehabilitated, or because of pathology, but that person could live in the community with the necessary support. So that's what we were taught by the convention of people with disabilities, that barriers are not set to people, but rather it has to do with the lack of social response to include, to embrace those people. So we'll keep the crisis service, and we will do that work with chronics. And we were thinking about some having some hospital for elderly, for children, and also thinking about health or something integrating. We will create 3 clubs, one or 3 sectors, one sports, one for children. I mean, thinking about people who need support. So this place will be open for a whole community. So on the one hand, we have the hospital, and well, around it, you will have these centers. So hospitals, clinics will be a place with a better standing in the community for people to go and occupy these places, and even for them to buy products made by patients. So this is a really all-encompassing program where we will be thinking the community and having as a fundamental access, which is the most important. And I don't know if I said it early on. I mean, the real protagonists of this reform are people with mental disorders. The center should be the people with mental disorders and the community, because you cannot think of having a protocol, but rather thinking about tailor-made solutions about specific treatment each of these persons need from clinic, and thinking this as like an extension of the clinic, where we could include all perspectives and everything that has to do with everything that person needs. So that's what we're working on. That's what's going on in the province of Buenos Aires, in the rest of the country. At least from the national government, there's political will for the national act to happen, to be enforced. Well, because in the midst of it, we have a bunch of other emergencies and needs. But, well, I hope this actually happens. Because, well, we're pretty much undergoing this crusade. Thank you very much. That's it for my presentation. Nadia, thank you very much for your comments. Well, participants said, so we've had today complemented each other. For the case of Anna, she talked about a very broad panorama on how to think about mental disorders and different attention models. Shoshana, she mentioned the problems being faced by mental health system in Mexico, some hard facts. And case of Nadia, she told us how this is being lived in communitarian environment, especially with this mental health act in Argentina. Due to time constraints, we will only have 3 questions. What I tried to do was trying to get what questions were repeated, and I will ask these questions to the 3 of you. The questions are starting by Anna, Shana, and then Nadia. Questions are: how do you leave this communitary attention in times of COVID? That is all these experiences told by Nadia and Shoshana. So how are you living this? How has that changed? If that integration, because it needs to be very direct to the inside of the hospital and outside. The second question is in the immediate term. among the time where you have other needs, is there really possibility to increase the budget for these type of situations? Can you see in the near future this changing, or do you think it's not going to be possible? And last, there's constant talk, but we need to know how is it that we can combat stigma surrounding mental health, not only from the community, but also from the government, because it's thought as a non-urgent problem, something that we can keep delaying. Why mental health issues are less important, especially under a pandemic. So please be brief. Anna, Shoshana, and then Nadia. Go ahead, Anna. Thank you, Hugo. I think I will let Shoshana and Nadia answer the first question, and I'll focus on the second and the third, because I'm not that close to changes in community attention before COVID. But as per the possibilities of increasing the budget under a pandemic and probable or real economic crisis, which we don't know how long it will take to recover, I think that there's a margin for this budgetary increase. Because let's think that tending after mental health, especially with the prevention and integrating focus, something that tends to offer resources for people to solve their ailments, will entail a reduction in expenditures in healthcare afterwards. So, having good mental health conditions will reduce problems like abandonment of treatment. It will improve prognosis of recovery of other types of physical problems, and they reduce the incidence of physical disease. So, person with a good emotional effective life gets sick less or is under less risk of certain types of accidents, certain type of problems happening. That will further reduce the costs of attention, physical health. Okay. So if we design strategies under that logic, then we'll be able to redirect budget to mental health, looking for that redirection to be cost effective. That is, that it meets or it attends certain problems with certain strategies that will entail later savings in other types of problems. Same goes with violence and crime and things of this nature. So it's not creating money out of nowhere, but redirecting the money that's been used to solving and patching up later problems to try to avoid them from the get-go. So in that sense, I think that we do have a margin to significantly increase the budget that's allocated to mental health. And this is necessary if we aspire to having a country or a society where the well-being of people comes first. And about question number 3, what to do before the stigma? I think that there are many ways to do this. There's a lack of information, that's true. General public has little access to knowledge, to updates or to concepts related to mental health. So people don't have a problem saying that they're depressed because X, Y, or Z thing happened, but they do have problems saying that they have depression. So I think that an important strategy is to increase access to information, as well as the way in which we understand the day-to-day. That is to say, if we put on the table the subject that if I feel bad because I am in a toxic or adverse work environment where there's abuse, where there's a series of conditions that shouldn't be there, then that doesn't seem a problem of mine that I cannot adjust to an office in specific or to certain labor demands, but we can set on the table that that office or that context, that work environment is giving me problems which I shouldn't be dealing with. Because it's not really a matter of me accepting or adjusting to negative conditions, even illegal sometimes. But we need to change the concept to be talking about meaningful reforms. And we should increase a little bit more processes that generate these diseases, so that would change the stigma that burdens systems related to health, mental health. And it should also target the policymakers, people implementing the services, and so on and so forth. So it's not only people who might be having a disorder, but people tending after them, more people responsible in designing the strategies so that they can receive support that could benefit them in terms of their quality of life. Now, Dr. Shoshana Berenson. Thank you very much for questions. And what about community attention under COVID? What Nadia said is very important. What is that we understand by community, and what's the scope of community? And like she said, I mean, this is one of the most complicated part in trying to communicate and work with the community and health. And I mean, where does community stops and the hospital starts? So the advances are not as we desired. I could tell you that within the webpage, general webpage of the government country, we opened up everything pertaining to mental health. So we had this proposal where the university is working, the Ministry of Health, the National Psychiatry Institute, and many more institutions working on this, providing psychological help and online intervention, if it's necessary, also psychiatric support to the population and to the people they're treating. So I think that that's a good example, a great example on how we responded before the pandemic. What's true is that health workers, haven't had the response that we were expecting because of all the conditions. But I think it's an example of actions that doesn't happen through the community necessarily, like Nadia said, but that does allow to bring together what institutions are doing to what people need and the options really available for the people. And I think that's very important. Now, regarding increasing the budget, I think that what Anna said is very true. But it's also true that the budget is not correctly allocated. If I have 3 pesos and I spend everything in the hospital, I mean, what about promotion? What about prevention? What about outreach to the community? So I think something more realist. I mean, it would be great. I mean, everybody would like to increase budgets for mental health, but mental health attention. But I think that we should better allocate it, and this possibility of migrating to a more community or based work and community attention. I mean, lower levels in the hospital. I think that that's a big area of opportunity to do what Anna was saying. I mean, if I have a general hospital mental health, I would save in a psychiatric hospital and its infrastructure, and that will allow, I mean, some what I would be spending at the hospital, I could be spending in other systems. So I believe that we need to think in increasing, but also in redistributing the budget, however we get for mental health. And last point, I mean, it's $60,000 question. I mean, if everything pertaining to research and work in mental health, how to combat the stigma, because it comes from different sides. The construct mental health, I mean, it turns out being morbid and not as a disease, but the associated stigma starts from the media, the way in which we construct and understand the disease and the way we assess it. I mean, I could really elaborate on this, and I will have 3 minutes, but I mean, an important thing that happens that as long as people go to these clinics saying I come here because I'm sad because my spouse left me and that makes me sad. I mean, depression is just a symptom. I'm not here because I want depression gone. I mean, that be gone if my spouse comes back, or if you help me understand why he's gone. But I think that this type of condition rather increased stigma alongside historic stigma. I mean, they were separated. I mean, it's not a health problem. So being able to revert this has to do with destigmatization of mental health, for people to learn more, but also healthcare workers to better understand how people construct these problems and, well, pretty much by providing attention accordingly. So that's part of what you were saying, and that's it from my participation, so let's not take more time. Okay, doctor, thank you very much. And finally, Nadia Berkovich.
In relation to the attention and community mental health and COVID, of course, there are some cases that the program was had some difficulties with community visits, and on the visit, and that question of going to a home and having this care within the quarantine that would make it harder. And we had to think of many things that so you had to follow many protocols that would make attention harder. So, but on the other hand, the everyday life was already difficult, and due to the protocols, it became more difficult. But in the beginning in Argentina, we had a very strict quarantine, and from there on, we started to have something with people that would have medication once every month. They would take the medication to their houses, and the attention was through the phone. From there on, we started to see that there were many people that would live extremely far from the psychiatric hospital, like 40 kilometers, and that they had a health center closer with a possibility of community health services and somebody that would be aware of these services. And maybe this person would be living at 200 meters far from this place. But they had this reference of this greater, bigger hospital 40 kilometers away. So the pandemic helped us to distribute resources and people in a better way. We implemented other strategies, with the infections in popular neighborhoods. I heard that in the university, so we could start thinking of community attention of COVID, and this opens opportunities to think of community attention to other kind of pathologies. We had phone lines for people that were having trouble with the COVID, toll-free numbers or low-cost lines. So we implemented different measures that allowed us to continue working. And obviously, there are things that are more complicated in the pandemic. But I say this due to the real georeferencing and to allocate resources. So this gives me a chance to talk about money allocation in relation to what Shoshana was saying. So resources are misdistributed because sometimes the person is not in a nice place, and probably that's true, but the cost of the attention for this person is pretty high, and we at the hospital think of this, that as long as we can externate people, then people are going to be doing work in the community in order to generate work with the professional teams that we have, so that they will be able to go outside. And of course we need more money, but not that much, because that great psychiatric hospital, besides being obsolete, is pretty high, pretty expensive. So the stigma, I agree, is for having a complete talk about this within the proposals that we have for the reformation in the hospital. We include proposals open to the community, so that the hospital would not only be the receiver of these people, but it is evident that the greater knowledge you have about the people with mental disorders, the idea of danger goes down. So if I work with a person with a mental disorder, I'm not, with a person that is going to be violent. So the possibility of thinking of a space, of a real inclusion of people with a mental disorder in community spaces that would be useful for the community, that's a way to deal with this. It's not something fast, but in this program that I was talking to you about, we have a community center where we have workshops for more than 20 years. There's a yoga workshop there that you can go there in the morning, the person that lives 2 blocks away, and also the person that is still here in the hospital, and they practice yoga, and sometimes they talk, and maybe not more than that, but there are some studies, and the person that goes there because she lives close, she says, I thought they were dangerous, but now I know her. I know Juanita and Susana, and I think they are not that mad. And look at what she has suffered. So, of course, poor is not the best word to use, but I prefer to use the word poor rather than mad. It takes time, but it is possible. Thank you very much. As you well said, several things. So I will take your word. There are some other things to talk about, to invite you to come other time to talk about all this. I really thank you for being here. In other circumstances, I would give you your physical certificate, but I will do it virtually. So thank you very much. We'll meet once again talking about this topic, which is fundamental for people to live with a well-being. Thank you very much for those that were among us, and we expect you to be here tomorrow and on Friday. So Anna, Shoshana, and Nadia, thank you very much, and I hope you will be okay. See you soon. Thank you. See you. Bye-bye.